Yeah, so thank you for this opportunity from Double Medical, and also to the esteemed speakers. Excellent presentations by the previous two speakers, and my colleague from Thailand, Dr. Wacharapong, your cases was amazing, really good. Okay, so I'll start. So we are talking about neck or femur fracture fixation in the young versus the elderly. And my name is Dr. Jeffrey Jaya, and I'm an orthopedic surgeon in HTA Kuantan. And I also do arthroplasty. So my outline of my presentation today is introduction, anatomy and blood supply, classification by age and anatomical location of fracture, biomechanics and open reduction internal fixation, complications, and lastly arthroplasty. So intracapsular femoral neck fractures are commonly seen in the elderly after a trivial fall, and in younger patients younger than 50 years it's actually uncommon, roughly about 2 to 3%, often due to high energy trauma. So we have to differentiate between the elderly and the young adult with respect to the osseous and vascular anatomy, mechanism of injury, associated injuries and fracture pattern, and also the goals of treatment. So what we find is in femoral neck fractures in young adults, there is a very high incidence of femoral avascular necrosis and non-union. So some of the literature reports a range of between 12 to 86% in younger patients after femoral neck fractures, especially by this study in 2008. So the reoperation and salvage procedures such as osteotomies have high failure rates. And for the young patient, obviously the arthroplasty is not ideal given the higher level of activity which needed and their age. And achieving an absolute anatomical reduction and stable internal fixation are imperative for a good outcome. So there are few issues which are debatable and still controversial, especially the time to surgery, the role of capsulotomy, and also fixation methods. So coming back to the anatomy and blood supply of the femoral head. So we know medial femoral circumflex artery, lateral femoral circumflex artery, and the obturator artery are the main supplies. So the obturator artery is via the ligamentum teres, the LFCA via the ascending branch of the inferior metaphyseal artery, which supplies the infra-anterior part of the femoral head, and the largest contributor seems to be the MFCA, which is the medial circumflex, to the supralateral aspect of the femoral head. And the lateral epiphyseal artery from the MFCA supplies the major part of the posterosuperior aspect of the femoral neck, as shown in this diagram, as you can see. So it's important for us to know that there is an intracapsular arterial ring, which is subsynovial, mainly from the branch of lateral femoral circumflex, and the subsynovial and also the extracapsular arterial ring, which is from the MFCA. All right, and from here you have your obturator. So what are the causes of AVN? It is hypothesized that vascular damage from the initial femoral neck fracture, quality of reduction or fixation of the fracture, whereby if you do not restore the flow to the distorted or kinked arteries, that causes higher chance of AVN, and also elevated intracapsular pressure. So when we classify by age, there are various studies which say varying ages, but generally we take young neck or femur fracture less than 60, or some even say 55, or mid-range between 60 to 75, and elderly neck or femur fractures more than 75. This is because there is a difference in the management options. So then coming to the anatomical classification, we all know the subcapital, transcervical and basicervical as shown in this diagram, and the parts of the proximal part of the peritrochanteric region as labeled here. So we all use the Garden classification of the hip fractures. As we know, Garden 1 to 4. Garden 1 is valgus impacted, undisplaced, incomplete fracture. Garden 2 is undisplaced, complete. And Garden 3, complete fracture, which is incompletely displaced. And Garden 4, it is completely displaced and complete fracture. So for younger patients, we prefer to use the Powell's classification, which is based on the orientation of the fracture line, and it is in relation to the horizontal line plane, whereby 0 to 30 degrees, up to 30 degrees is a power 1, 30 to 50 is type 2, power 2, which is less stable, and the most unstable is the type 3, which is up to 70 degrees. So the biomechanics, when we talk about biomechanics, we know that the major risk factors for elderly patients who have femoral neck fracture is the bone density, multiple medical problems, and the propensity to fall. Whereas in young adults, it's more of an axial load with the hip in abducted position, which causes commonly a basicervical neck or femur fracture. So usually the patient will present with a shortened, flexed, and externally rotated leg. However, in the elderly, the subcapital neck or femur fracture is commoner. Okay, so the more vertically oriented fracture, as I mentioned earlier, is biomechanically more unstable, powers 3. And these characteristics have important implications in terms of obtaining and maintaining a stable fixation to allow union. So like I said, we prefer the Powell's classification for young because we know that it's more descriptive and it's based on the fracture pattern, and so we need to be able to achieve a stable anatomical reduction to achieve a good outcome. And the type 1 is relatively stable because of the compressive forces that predominate, valgus impacted. Whereas the fracture pattern in Powell's type 3 is common in young, is vertically oriented, and there's increased shear force, varus movement, and instability. So it is more difficult to achieve the fracture fixation in a type 3 and higher risk for fixation failure, malunion, non-union, and lastly AVN. So coming to our management goals, as we know, our goals of treatment for the elderly will be immediate weight bearing with mobility as tolerated and minimizing complications of seen with prolonged bed rest. Okay, so the surgical options can be open reduction and internal fixation, hemiarthroplasty, or total hip replacement. So we need to consider the patient's physiological age, level of activity, medical comorbidities, and the degree of the bone density. So for young adults, preferably it's an open reduction and internal fixation, and the main goals are to preserve the femoral head, avoid AVN and non-union. THR and hemi is not ideal in the young due to the high functional levels, and for the good outcome in the young, anatomical reduction and stable internal fixation is paradigm. And these are the issues, whether it's a closed versus open reduction and the role of capsulotomy and the time of surgery. These are controversial. So if we follow the national guidelines of UK, which is the NICE guidelines, which most of you are aware of, for neck or femur fractures, it is recommended for surgical procedures, we have to operate with an aim to allow full weight bearing without restriction in the immediate post-op period for neck or femur fractures. This recommendation was in 2011. And the next one is offer replacement arthroplasty, which is THR or hemiarthroplasty to patients with displaced intracapsular hip fracture. And it is advised to offer a THR rather than hemiarthroplasty to patients with a hip fracture with the following conditions: if they are able to walk independently outdoors with not more of a use of a stick, this is for elderly, and they are not cognitively impaired, that is no dementia, and are medically fit for anesthesia and the procedure. This recommendation was in 2017 by the NICE guidelines. And furthermore, it is advised to use a proven femoral stem design rather than an AMP or a Thompson. Okay, so we use, and it's advised to use cemented implants in patients undergoing surgery with arthroplasty. And they recommend the anterolateral approach in favor of a posterior approach when inserting a hemiarthroplasty. And it is advised that you have to use an extramedullary implant like DHS or sliding hip screw in preference to an intramedullary for those patients with the trochanteric fracture above and including the lesser troch, A1 and A2. So it is advised for intramedullary nail for patients with subtroch or even basilar neck of fractures. Okay. So the management options for the neck or femur fractures in young patients, say less than 50, 55, the general rule is to preserve the own femoral head as far as possible. And for basilar neck or femur, of course, we have the option of the APFN or the PFN and screw fixation. And for transcervical neck or femur, cannulated screw fixation or sliding hip screw, DHS, or plus minus with screw fix, or the latest implant, which is the femoral neck system. And of course, options of subcapital neck or femur will be cannulated screw fixation or DHS or the FNS. And so, as we know, this is one of the examples of the APFN from Biomechanics, and it's a good option for subprop and basilar neck of femur fractures as well. And so, for the reduction, it is advised that temporary reduction of the femoral neck fracture by extension and internally rotating the leg should be avoided because this increases the intracapsular pressure. So, several authors show that the intracapsular pressure changes with hip position in femoral neck fracture, and it is highest when the hip is in extension and internal rotation, and it decreases significantly when the hip is in flexion and external rotation. So, there are a few techniques, and one of the techniques, Ledbetter technique, is given. It was in 1939 introduced, whereby a close reduction, you have to do this maneuver. It is done by flexing the hip to 45 degrees with slight abduction and followed by extending and internally rotating the leg while applying the longitudinal traction. Some of the other maneuvers for a close reduction is Whitman's maneuver, whereby the fractured extremity is on a foot plate, traction table, and externally rotated position, whereby the limb is abducted 20 degrees and traction applied. So the extremity is internally rotated then to 20 to 30 degrees, patella facing inwards, and these are the other close reduction maneuvers. Okay, Massey, McElveny, and Dale. So the anatomic reduction for young, especially, you have to get an absolute anatomical reduction visualized on the fluoroscopic imaging before considering a percutaneous fixation. There should be a very low threshold to proceed with open reduction and internal fixation if there is questionable reduction. It is recommended that surgery should be done with the patient in supine position on a radiolucent table and the leg draped free. What is the recommended approach? Usually it's anterolateral Watson-Jones approach, whereby we directly visualize and reduce the fracture. In some difficult comminuted fracture, the dual approach is recommended, whereby we do an anterior Smith-Peterson approach to directly reduce the fracture, and we combine with anterolateral or modified Harding with a smaller lateral stab incision for the screw incision, the comminuted screw. And some reduction tips or tricks is we can use K wires as a joystick to maneuver the head, and assisted reduction with shunt spin or bone hook distally over the shaft to obtain a perfect anatomical reduction. It's preferred, if you cannot get a perfect reduction, slightly valgus rather than a varus fixation. So these are the issues. Earlier I was talking about timing of surgery. The data is inconclusive. Whether this fracture should be fixed urgently or emergently or can wait till the next day. But advocates of early surgery show that prompt reduction of displaced femoral fracture, they will unkink the vessels, and intracapsular decompression to decrease the intracapsular pressure. So open reduction internal fixation of femoral neck should be performed as soon as the patient is considered stable and cleared to undergo anesthesia. The urgent operation allows early reduction, capsular decompression, restoration of the anatomy, and restoration of femoral head vascularity by unkinking of the vessels. So, in the controversy of capsulotomy, so increased hip intracapsular pressure results in tamponade effect and reduces the blood flow to the femoral head, hence increasing the chances of AVN. So the conclusion based on all the randomized control study is the capsulotomy should be done, recommended to perform. And implant choice can be cannulated screw, DHS plus screw, or the femoral neck system, which is the new. So what are the kinds of orientation or the pattern of this cancerous screw? So we all know the inverted triangle, especially in the timing as early as possible, usually in Paulos type 1 and 2, 3 screws. And the additional techniques like Filipov technique is used in more osteopenic bone, whereby the distal most screw is fixed in a more distally at the more cortical bone, and it's fixed. You can see the orientation there. It is fixed more posterior to anterior to get more stable fixation in dual planar, and the orientation is like an F shape. All right. So what is the criteria to say that this is an acceptable reduction? We use the Garden Alignment Index and the Lowell's Alignment Theory. Basically, we don't want to fix it in varus. So we want angle between the medial shaft and central axis of the trabeculae should measure between 160 and 180. Anything below that is varus, above that is valgus. So if you cannot get a perfect thing, slight valgus is fine. Angulation in the lateral should be 180 degrees, deviation more than 20 not acceptable. In the Lowell's Alignment Theory, we should get this S or reverse S. If the image is a C, the fracture is not reduced. So in terms of the BHS or sliding hip screw, so basic cervical fracture with comminution provides more stable fixation than 3 cancerous screws. These are what the study shows. Blair et al. Is one of the authors who did a biomechanical cadaver study to evaluate 3 different fixation techniques. And they recommended sliding hip screw over multiple cancerous screw because they found that this was more stable. And they found that derotation screw did not add any superiority to the fixation. So what kind of fractures are amenable to sliding hip screw? More vertically, Powers type 3, whereby the dominant shear force that is seen with this high angle fracture leads to a high rate of failure. So we want to prevent the varus and the inferior translation of the proximal fragment. Debler et al. Showed that sliding hip screw had less inferior femoral head displacement, less shearing, and also greater load to failure when compared to 3 cancerous screws. And in this study, Bonner and Weber looked at 4 different methods of fixation. One is sliding hip screw with derotational screw, without derotational screw, cancerous screw, and also angle grade plate. And what they found, sliding hip screw with derotational screw is the best implant for this fracture pattern. But the problem is sometimes a lot of bone is removed and we use this large compression hip screw. So that is another controversy whether we damage the femoral head blood supply. These other salvage procedures like valgus osteotomy and muscle pedicle bone grafting as an augment is to reduce the incidence of non-union. And Mayers et al. Noted that there was a large defect in the posterior neck of femur in 70% of their case series. So using quadratus femoris muscle pedicle graft provide good blood supply to the femoral head and acted as a structural bone graft to buttress the femoral neck. And the reported rate of non-union in these procedures was 10% and avian was only 5%. So what are the complications? We talk about non-union and avian. So when you have non-union, Parker reported post-op non-union occurred in 13 out of 470 patients, and out of the 13%, 17% were Garden stage 3, 4 and displaced fractures, and 8% were Garden stage 1, 2. And this was statistically significant. The avian incidence was 15 to 40%, that's very high. And recon options to preserve the hip include osteotomy to unload the segmental area of the femoral head collapse, femoral head core decompression, and free vascularized bone grafting, and also hemi. So the other options, once they develop this complication, there's no turning back. We have to go to either a hemi, bipolar, or THR. So when talking about the elderly, there are roughly about 70,000 hip fractures every year in the United Kingdom, with total costs exceeding 2 billion. And mortality is very high. It is 10% dying within 30 days of admission, and 30% mortality within 1 year. And so many survivors are unable to continue living independently, and 4.5 million people are disabled every year by hip fracture. So the role of arthroplasty in elderly neck of femur is immediate stability, immediate weight bearing, and early mobilization. Currently, for elderly above 75, unipolar or bipolar options is a good option where you can use a larger modular head, as opposed to THR, which shows a higher risk of dislocation. But it's maybe an option for elderly, provided they are cognitively intact and independently mobile, with good family support, not in nursing home, and fit for anesthesia and surgery in terms of comorbid. So this is an example of a Thompson, this is a bipolar, and this is a total hip cemented in an elderly neck of femur fracture. So the better functional outcome in THR, studies have shown randomized control study whereby total hip replacement, higher risk of 12-month dislocation. This particular study, Metcalf Judge in 2019 showed 33% lower risk of 12-month revision for total hip patients, contrary to the RCT finding of no difference between THR and hemi. The most important fact is 58% lower risk of 12-month mortality for patients undergoing a THR. So when comparing unipolar or bipolar, when you compare 21 cases of bipolar versus 20 cases of Austin Moore replacement over 1 year period, this study which was done by Somashekar Krishna found that patients with bipolar had better functional outcome in terms of range of motion, better gait, no limp, and ability to use public transport and cut toenails. The mean Harris hip score was better with bipolar group. They found higher acetabular erosion in unipolar, especially Thompson and AFP. But however, in our country and few of the other countries. Of course, cost is an issue. The cost of a Thomson AMP is much cheaper than a bipolar. So at 10 years, bipolar has the lowest cumulative percentage revision for fractured neck of femur, followed by unipolar modular and unipolar monoblock. This is from the Australian Registry 2019. So the difference in outcome between classes is most apparent in patients aged less than 75 years. So the NICE guideline says use a cemented THR for elderly, proper cementing technique to prevent bone cement implantation syndrome, and multidisciplinary approach together with the orthogeriatricians is important to manage these patients, and early surgery to prevent complications like hospital-acquired pneumonia, decubitus ulcers, DVT, and PE. So the Australian registry showed that total cumulative percentage of revision in primary THR for a fractured neck of femur is 7.7% at 10 years. That is really good. And when they analyzed the fractured neck of femur, they found that there's difference in outcome with respect to fixation and age. For patients aged less than 70, there is no difference in the rate of revision between the three fixation method, which was cemented arthroplasty, cementless arthroplasty, and hybrid. So they found in less than 70, there was no difference. However, for patients more than 70, it was very obvious that the cementless fixation had a higher rate of revision than cemented fixation over the entire period, and especially the first 3 months. This was due to periprosthetic fracture and intra-op complications compared to hybrid, and no difference in rate of revision when hybrid is compared to cemented. So this is the graph which is showing. You can see the lowest revision rate in the cemented. And when you compare hemi, unipolar, monoblock, unipolar, modular, and bipolar, revision rates in unipolar monoblock was higher than THR after 3 months. However, the unipolar modular had a lower revision rate than THR in the first 3 months. Between 3 months to 1.5 years, there was no difference between the unipolar modular versus the THR. But after 1.5 years, the revision rate of unipolar modular was much higher than THR. So THR was better. Bipolar had a higher revision rate than THR only between 1.5 to 2.5 years, following which after 2.5 years there was no difference. More than 70 years, unipolar monoblock had a higher revision rate than THR after 3 months, but there was no difference in bipolar versus THR in less than 70. But more than 70, bipolar had a lower revision rate than THR for the entire period. So this is what that example shows, that you can see more than 70, bipolar had the lowest revision rate. So the take-home message from today's presentation is, in young neck of femur fracture, cannulated screws, sliding hip screw or DHS plus minus derotational screw, femoral neck system or for basilar neck APFN is an option. The controversy is, should we be thinking of THR in the young patient as a primary option? As we know from the studies, it shows a high risk of rates of non-union and AVM despite all the good fixation techniques. And so this is a controversy. However, in the elderly, early surgery is paramount, immediate weight bearing, mobile, good functional status with no cognitive impairment, THR is a good option with active physiological age. Hemi, unipolar and bipolar, more for the age more than 75. Thank you for your attention.